wanted to thank Carol and Harbor House and St. John's for the invitation. I'm really happy to be here today with you. So basically, what are lymphomas? So lymphomas are essentially cancers of the white blood cell. So we all have white blood cells in our body, and white blood cells are really there to help our body fight infection. Our bodies are covered in white blood cells on the outside, on the inside, and they also circulate through the bloodstream. You can think about it as these guards to entry, preventing things from coming in or going out. And they're a normal part of our anatomy in our body. So lymphoma is a process whereby one of those white blood cells, the lymphocytes, starts to develop an advantage where it grows uncontrollably. And it can start to form either a cluster or a lump or a mass, either on the outside of the body, like on the skin, or on the inside in the bloodstream, or within the lymph nodes, which are these little pockets of white blood cells that we have within our body. All of our blood cells actually originate in the bone marrow, and as Lynn alluded to, when there's something inside of the bone marrow that's taking up a lot of space, it doesn't let your healthy blood cells get made. And so that's one of the things that we often see in lymphoma is that people can have low blood counts, or they can present with a mass under their arm or in their neck or somewhere else, or they can start to feel tired, or their blood counts start to go down. So those are some of the potential things that you can see with a new diagnosis of lymphoma. But when we think about lymphoma, it's actually over 100 different diseases. And there's lots of different subtypes. There's Hodgkin lymphoma, which is one form. There's non-Hodgkin, which is another big category. But loosely, we think about them as either fast-growing, more aggressively behaving lymphomas that require treatment immediately, or slow-growing, more chronic lymphomas that people can live with for a long time. Sometimes they can be treated, and sometimes they don't need to be treated. So that's kind of the way that we think about them. And depending on the person, not everybody actually needs treatment for their disease. Like Lynn mentioned, not having treatment for 12 years. That's because all of her numbers have stayed really, really stable, and she hasn't met what we call that inflection point, that criteria for treatment. So not everyone needs treatment, but sometimes people do need treatment. And we think about that as, well, when is treatment indicated and why? So we always want to think about 10 steps ahead, and we don't want someone with lymphoma to eventually need emergency treatment. Sometimes we have to have preemptive treatment to prevent complications. Like if these lymph nodes are pressing up against organs in the body, that could put them at risk of a complication, that would be a reason to treat. Or if they're developing night sweats or losing weight, or if there's a blockage in their organ, that could be a very dangerous situation, so treatment would absolutely be required at that point. And so there are some reasons to treat immediately. Sometimes if there's an aggressive lymphoma, if we leave that untreated, that could be a life-threatening problem. So we have to be very preemptive at treating lymphoma. Any questions so far based on that? Okay. So when we think about cancer treatment, cancers essentially what they all have in common are these are cells that divide quickly and they can live forever. So they have this advantage that if we just leave them unchecked, they'll just keep going. So we must stop them if we are to get rid of them. And so when we think about cancer or any rapidly dividing cell, how do you kill a cell? How do you kill anything? Well, when we study lymphomas in the laboratory, and if you grow lymphoma cells in a dish in the laboratory, and you just add acid to them, or you add different ingredients to them, you can kill any cell in the laboratory in a dish. That doesn't mean that we can recapitulate the same thing in the human body. Because if we drink acid, for example, well, lymphoma will die, but so will many other vital organs, so we don't want that. So we have to think about creatively how can you kill cancer cells in a way that doesn't also harm the person. And traditionally, ever since probably the early 1980s, 1970s, 60s, chemotherapy started to become the mainstay of treating cancer. So I did my residency at Yale, and I'm proud to say that Yale was the first place where combination of chemotherapy was tested for the first time in lymphoma. And people were very nervous about adding more than one drug at the same time because they thought it was way too dangerous. If anything, you could only give radiation, which is high energy X-rays, or you might use one medicine at a time, but no more than that because it's way too dangerous. So at the time it was thought, well, let's be a little bit more innovative and add 2 different chemotherapies given kind of one after the other, because we want to try to target this disease in a different way. chemotherapy kills cells in a variety of ways. As you probably remember from biology, when a cell is dividing, it has to undergo mitosis. I know that's kind of reaching way back, right, for some of us, but basically the cells have to divide, and then they have to have their DNA grow and, go into the next cell. So your DNA, killing DNA or interrupting the DNA is one of the most practical ways that we kill cancer. So that's one form of the chemotherapy. Sometimes they just interrupt the DNA and put like a little kink in it. Or another time, another form of treating cancer is by kind of targeting some of the surface proteins that it has. So if you think about like a little sphere, and that's the lymphoma cell or any cancer cell, and it has like a little thing sticking up, those are called little proteins on the surface, and sometimes by targeting those proteins, that's what immunotherapy can do. You can be very specific at kind of catching that specific protein and killing the cell that way. But there's several other ways. So the idea is if you kind of say, well, it's like thinking about winning a war. Well, I'm going to do a drone strike, or I'm going to do, I'm going to get on the battlefield, or I'm going to do all these different ways. That's exactly what we think about killing cancer too. You try to have to use different strategies all at the same time. And the reason we do that is because the cancers can become smart and then learn how to bypass some of those ways. So if we only use one strategy, like interrupting its DNA, well, the cell's going to learn another way to divide and maybe bypass the DNA and use a different strategy. So that's the idea behind using a lot of different things together. Does that make sense? So chemotherapy has its limitations. So like I said, the cells can outsmart the chemo and learn how to grow despite chemotherapy. But then the other thing is that over time, you start to accumulate a lot of side effects from chemotherapy. It starts to really take a toll on the body if someone needs to have chemotherapy multiple times in their life. And so the idea is, well, what can we do to kind of protect the patient? And I talk a lot about this with my patients. I sort of think about like this is one moment in time, but then what about the next 20 years of life? We have to protect that time too. It's not just today, but all of that survivorship time is really critical. So we need to protect the health that's coming after this is over. And so we need to be really strategic about how we approach cancer treatment so that we can protect that future life expectancy. And so those are some of the limitations of chemotherapy. It's called resistance when the lymphoma starts to outsmart the chemo. It's called becoming resistant. You have accumulation of side effects, and then you really can't get more treatment in the future. So then the whole concept of, well, what besides chemotherapy can we use? And the idea of immunotherapy came into play. So there's a lot of types of immunotherapy. So the very first immunotherapy was developed in probably the 1990s, and it's called rituximab. Rituximab is a very commonly used medicine for lymphoma. And what it does is that it targets the surface of the lymphoma cell, and then it kind of tricks the lymphoma into thinking like it's being activated, like the cell is being activated, but instead it calls the other immune system cells around it to kill the cell. So rituximab was one of the biggest revolutionary treatments ever to happen in B-cell lymphomas. Now there's B-cell lymphomas, there's T-cell lymphomas, so not all lymphomas can use this particular drug because it has different surface targets. But the idea is that you've now given your body an advantage because you're using an immunotherapy and chemotherapy at the same time. So now that has led to drastic improvements in survival because now, the lymphoma or the cancer, because it can be used in other diseases, it kind of sort of is paralyzed and it doesn't know what to do next. And so that strategy has really kind of continued to be built upon. So if you think about how these immunotherapies have advanced, one of the things that is really new is something called bispecific antibodies. So what that does is that it targets, it's one little molecule, like a Y-shaped molecule, and it targets one surface on the lymphoma cell, and it targets another surface on your immune system cell. And so what that does is that it brings both of those things together, and your immune system can now kill the lymphoma cell, which is completely revolutionary. Like we never thought that we could use our own immune system to kill cancer, but now we can, because these immunotherapies are teaching your immune system to recognize cancer. And the funny thing is that all of our immune system can fight cancer at a very low level. And we are probably fighting cancer like on a regular basis, even right now, and we don't even know it. But the issue is that it happens at a very, very low level. And so what happens is when a cancer develops, one of the strategies that cancer cells do is that they tell that surveillance system to go to sleep. And it's suppressed. So now this anti-cancer response that we normally have, even at a low level, is kind of like, it's not active anymore, it's suppressed. So these new immunotherapies are reawakening the immune system and allowing cancer treatment to be a lot more effective. And that's chemo-free, zero chemo in there, nothing. It's just your immune system working for you, which is pretty amazing. So one of the things that I had in my slide set was that one of the biggest things that I see is Hodgkin lymphoma, which is a type of cancer that can affect a lot of young adults. And imagine being, 20 years old and being diagnosed with a very life-threatening aggressive cancer. So those are the things that we need to really, really do better on. So here at Wilmot, we led an international study in children and adults looking at adding immunotherapy to chemotherapy for Hodgkin lymphoma. There were over 900 patients that were included. Half of them got one form of immunotherapy with chemo, and the other half got another form of immunotherapy with chemo. And we learned that there was an improvement. One of the chemotherapy combinations did better than the other. So again, we compared one immunotherapy with chemo and against another, and we discovered that there was actually a better combination. And so now that's led to a drastic improvement in survival for young patients with Hodgkin lymphoma, which is really important. And again, that was developed here at Wilmot and a really big practice-changing type of trial. So that's kind of some of the research that we're doing. So that's sort of like a kind of a whirlwind tour of like a basic approach to cancer and some of the things that we're doing right now. But I just want to stop there and see what questions you might have or any experiences that you might want to share, because I know that you probably have some questions or other things that you want to think about.
Thank you, Doctor. I'm still a little unclear of the difference between immunotherapy and chemotherapy. It sounds like immunotherapy still you introduce some kind of outside chemical to treat the cancer. So what is the main difference?
That's a good question. So you're right, it's kind of like a chemical. So it's a medicine, but it doesn't work in the same way. So when we think of chemotherapy, it can kill, technically speaking, any cell, technically speaking. It's more specific for a cancer cell, but technically all cells can be vulnerable to chemotherapy, like the hair, the nails, the skin, the blood, and that's where you get some of the side effects. Immunotherapy is different because it's specific only to the lymphoma cell, and it uses your immune system to help kill the cancer cell. So that's the biggest difference. Even though it's a chemical, it's a medicine that you get typically by vein, but it doesn't really affect the other healthy cells in the body.
But you use them concurrently as well sometimes.
You can use them concurrently or you can use them individually, one at a time.
Okay, thanks.
A couple of times you seem to anthropomorphize cancer cells when you say the white blood cells, the cancer cells recognize what's going on and they then they operate in a different way. And they don't really recognize, or in a way that they don't have a brain of their own. And I know that I wouldn't understand this even if you did explain it, but am I making it clear at all? I wrote down, the phrase that I wrote down was the cancer cells have strategies, or the immune cells outsmart the other. Well, how they don't have a brain, so just in simple words for that I can
I was going to ask the same.
Yeah.
What does that mean?
Yeah, that's a good question. So when we think for lymphoma in particular, lymphoma happens to be a cancer of the immune system. So you have your normal immune system that's kind of doing what it's supposed to do, and then there's one. If you think about like a cluster of grapes, all green grapes, but there's one red one in there. There's one bad cell in there, but it happens to be part of your good immune system. That doesn't mean you don't have good some cells that are still working for you, but it's just a few of them have become cancerous. So under normal circumstances, your healthy, good immune system is still doing what it's supposed to do. What we're doing is targeting the cancer component of the immune system in lymphoma. If let's say we're talking about lung cancer, then it's the immune system versus the lung cancer cell. In lymphoma, it's the lymphoma cell, which is a white blood cell, but it's the bad immune system cell against the good immune system. And so your immune system is always helping to kind of fight against many things, good, bad, cancer, non-cancerous things. And so you have both of them working at the same time. I don't know if that helps to clarify things a little bit. Okay, is that?
But to go deeper, and I'm not gonna use the right terminology, that these are living cells, but they don't have a brain like a human, so how can the cell mutate, or like in my, I said, all I got was immunotherapy, so if 5, 10, 20 years down the road, I can't use the same drug because it recognizes that. Are these cells trying to thrive and stay alive if you're trying to, kill those spikes off, that it's changing and morphing? Because they don't have any, is it, they're trying to survive if they're changing?
Right, exactly. So your cells don't have a brain per se, but they still have mechanisms, they have ways of like thriving and living and staying alive. Think of it like, like a bacteria. Like if someone has pneumonia, and you treat pneumonia, you might still, like, given the right circumstances, maybe you go out or are surrounded by a lot of people or you get another exposure, you might have a pneumonia flare, let's say. So in some cases, the lymphoma is very suppressed to the point that it's almost inactive, but something could re-trigger it again. And so that's how lymphomas can come back. They can be suppressed.
These cells that you were talking about when targets that can morph into a different cell, meaning the cell's trying to thrive when you're giving certain drugs to it?
Yeah, I mean, it's trying to stay alive, and that's one of the things. So it's because they're a living cells.
Or something?
Yeah, they are trying to stay alive, so they're trying to kind of struggle against the chemotherapy. Ultimately, and most of the time, fortunately, chemotherapy, with or without the immuno part, will win and will, for the most part, successfully kill those cells, and kill them, and they stay dead. But sometimes there's like 1 or 2 cells that remain alive within that cluster, and they're just kind of staying asleep, let's say. They're alive but asleep, so they're not active. But then over time, it might just eventually die off, or over time, something could stimulate it to grow back again, reawaken, and then grow back again.
Some people get their reawakening, other people.
Correct, yes. And that's the whole concept of what we call relapse, which is when someone comes out of remission. If one of those cells that was presumably either sleeping or dead something has re-triggered it to grow back up again.
And how ironic that you had commented the immune system is always fighting cancer that people have that's asleep. Back in 1988, my ex-husband had Hodgkin's lymphoma, and the doctor told him back in '88, everybody has a form of cancer in their body. Just some of them stays asleep forever, and others will come to light that it gets triggered and activated. So I just couldn't get that concept. Cancer.
I don't know that everyone has cancer in their body per se, but I think that, when cells are starting to misbehave, your immune system is sort of like strategizing, like, okay, this guy's bad, let me kill these cells off. But when someone has a cancer diagnosis, unfortunately, one of the strategies that the cancer cell uses is to weaken that surveillance system. So these immunotherapies kind of reawaken the immune system so that they can fight off the cancers.
Okay.
Sorry, I've got one more question. You mentioned there are 100 different types of lymphomas. So some are more resistant to treatment than others, some are more lethal than others. Unfortunately, I know of 2 men who recently were diagnosed with lymphoma. One was treated maybe a year, the other was about 5 months, but neither one survived. So I'm wondering, is there certain types, when you're given that diagnosis, where right away you know that this is going to be an aggressive treatment that you have to follow?
Right, yeah, I'm sorry to hear about that. Yes, so there are some types of lymphomas that are highly aggressive, so they grow very, very rapidly. And you kind of have to, the chemotherapy is meant to really target those cells as quickly as possible. Sometimes those patients need chemotherapy that's given over, many, many days in a row, or over months, many months. So yeah, there's certain features about different lymphomas that make them much more aggressive and more resistant to chemotherapy for sure. And depending on some features of the disease, when you see the person, you can identify those things. Sometimes it's, we have different ways of what we call establishing prognosis. So in general, most lymphomas are highly treatable and in some cases curable, but there are some that, based on our prognosis calculator, we can say, well, this person has this feature that's really worrisome, or this genetic change, and those are kind of, when you add those all up together, they add up to a scenario where this person is more vulnerable to having the lymphoma be a bad lymphoma. So there are ways for us to tell those things at diagnosis, yes.
And if that person receives that diagnosis from Wilmot, would there be a benefit for that person to seek out another opinion at a nationally known cancer institute like Sloan Kettering and look at the different treatment styles that perhaps they might suggest?
Yeah, I mean, I'm a strong proponent of second opinions. Like half of my practice is seeing second opinions myself, so I think there's a lot of value in that. One of the things too is that you may not know this, but Wilmot just received its National Cancer Institute designation, which is a very, very high accolade from the federal government, recognizing us as the top 4% of cancer centers in the country. So that's a very nice, acknowledgement. But to your point, whenever you are in an area, in a cancer center that is highly specialized, like I said earlier, I only see lymphoma. That's one of the things that you might want to do. If you see, if you're getting your treatment from a cancer center where the doctor might see a lot of different diseases, you might consider going at least once to see a specialist in only that one disease. I think that's an important thing, especially for rare diseases. But there are guidelines that help us choose what treatments to select from, and those are pretty uniform. At Wilmot, all of us come from different training institutions. So some of us are from Dana-Farber, some of us are from Sloan Kettering, like myself. Some of us are from Mayo. So all of us bring like a different, perspective. And jointly, we see all new cancer diagnosis cases. We review all of the cases at Lymphoma Tumor Board. We discuss all new cases multiple times a month. And so you're always getting like multiple viewpoints. But I think it's always a good idea to get another opinion because it's valuable to you and to your case. So I'm a strong proponent of that.
Could I just say about that when I got my first lymphoma diagnosis, which is 9 years ago now, we went immediately to Dana-Farber in Boston because that's the name that we knew. And the doctor that we saw there was Dr. Odajita, I think her name was. And it came to pass that we found out that she and Dr. Casulo are friends, and in fact they were giving a paper together at a research convention the following week, and so they knew each other very well, and that was really reassuring and took away any feelings that we needed to be in Boston, because we didn't.
Sounds like you wouldn't want to leave Rochester,
Absolutely,
given
I
what
wouldn't want to
we're
leave Rochester. Our Boston friends, I don't know if you have Boston friends, but they may not leave Boston because of the medical care there, and there's no medical care anywhere else. Everywhere else, they use rusty saws to do the surgery. So that was what we needed to do, and it was very reassuring.
Mm-hmm. No, thank you for sharing that. And the lymphoma community is a small community, and I think that at the physician level, with sort of clinical researchers like myself and my colleagues, and so for the most part, we all know each other. So that's why I would not feel offended if someone wanted to go see my colleague at Dana-Farber or Sloan Kettering, because we all are friends, we collaborate. So I think it's a great idea. Now, there might be a clinical trial that's really interesting that we may not have, but someone else does, or vice versa. That would be a good reason to seek another opportunity, but that might not always be necessary.
One last question, because my mind escapes me exactly with the follicular lymphoma. What does follicular mean with the lymphoma? And is that one of the lymphomas that's a higher survival rate? Because I've been told I'll die with follicular lymphoma, not from the follicular lymphoma, because I get heart condition.
Right, so many of the lymphomas are more of the chronic, slow-growing forms, which patients can live with for years. Follicular lymphoma, probably 20, 25 years plus in terms of survival, very, very high survival. Even if someone has the disease in their body, they may not necessarily ever need to treat it. They may have it and not need treatment, or it might be treated successfully. So in general, it has a very good prognosis, yes. And then the way that we get the names of lymphoma, it's kind of in a boring way. It's just based on where, well, no, actually not that, not from your hair, but it's just based on how the lymph node looks. So the lymph node are these little pockets of white blood cells, like I mentioned earlier, our lymphatic system. That's where those white blood cells live. And if you were to just take out a normal lymph node from your neck and look at it, you'd see these little follicles, which are these little circles, where all the white blood cells live, just nice and quietly. So if a lymphoma comes from the circle, it's called follicular. If it comes from the margin, it's called marginal cell. If it comes from the mantle of the lymph node, it's called mantle cell lymphoma. So it's kind of boring the way that we describe it, but it's very intuitive, I guess. So that's how we describe them.
And they have it involved with 5% bone marrow. Does that mean one might have had this slow-growing follicular lymphoma for quite a while?
I think so. That's a possibility. They can live at such a low level and almost not be discernible that yes, it's possible that someone can have that for a really long time, but be completely healthy otherwise and have no symptoms.
And thank you all for being here. And now we invite you to have lunch with us. Continue the conversation as you wish. And again, thank you so much for being a part of this discussion.
Thank you.
Thank you.
And please, please, take the opportunity to get more information from our partners here today, Hope Lodge, Wilmot Cancer Institute, Blood Cancer United, and thank you, Blood Cancer United, and Sadie for providing lunch for us.
No, that was mine.